Students, this is Dr. Lisa Pullen. I'm going to be speaking about the treatment of obsessive compulsive related disorders. So you have 5 different disorders. We're going to discuss the ones that are highlighted: OCD, trichotillomania, and excoriation disorder. There's also body dysmorphic disorder and hoarding disorders. Assessment and clinical presentation. Again, students, this is a review. I went through all of this your first semester, and again the second semester. We're focusing on treatment. So I'm going to skip through this, and you can revisit that. The treatment. The goal of treatment is to reduce frequency and intensity of the symptoms, minimize the symptoms interference with the patient's life, just like you're going to do with any anxiety disorder. And the first line treatment is the use of SSRI in behavior therapy, like I had said earlier. They are equally effective alone. TCAs for OCD. Your tofranil there differs from other TCA medications. It is a potent serotonin reuptake inhibiting effect, but not selective for serotonin. Its metabolite, and I'm not going to try to pronounce that, inhibits the reuptake of norepinephrine. The effectiveness of tofranil and the SSRIs is equal in treatment of OCD, but the more numerous side effects of tofranil may make them a second-line choice for OCD. Endoxapan, I've mentioned that before, may also be effective for OCD symptoms when tofranil is not beneficial or intolerable. SSRIs for OCD, I've used Prozac, Lexapro, Paxil. I have not used, as I said earlier, Luvox. You see the side effects, students. These are the common side effects of most SSRIs. And then adequate trials of SSRIs for OCD. You typically have to get the dosages pretty high with your SSRIs for treating OCD. Antipsychotics for OCD. Your typical antipsychotics have not been found to be useful in the treatment of OCD and are not used because of their side effects and due to the extrapyramidal side symptoms and tardive dyskinesia. EPS symptoms, students, are like Parkinson symptoms, and your tardive dyskinesia, of course, can be irreversible. OCD with tics or Tourette syndrome, risperidone plus tofranil, SSRIs, and Haldol plus Luvox have been found to be useful. Long-term treatment for OCD. Long-term treatment for patients who have responded to an acute phase use of a medication usually includes maintenance of the patient on the medication for at least 1 year, and some are maintained indefinitely. Lower dosages of the anti-obsessional drugs may be used during the maintenance phase. The relapse rate with sudden discontinuation of medication is as high as 90%. Discontinuation should include a gradual taper to reduce discontinuation of symptoms of vertigo, dizziness, headache, vivid dreams, and irritability. Combination strategies for OCD, because only 60% of patients with OCD will show a response to SSRIs. Combination of SSRIs and other medications are often used because Luvox increases the amount of available tofranil. Combinations of Luvox and tofranil for patients who have shown a partial response to tofranil have been found to be effective. Students, I'm sorry. Clomipramine is anafranil, not tofranil. I apologize. Administered intravenously as initial loading has been used and may have a greater effect than oral loading. OCD, non-response to medications. Treatment resistant indicates patients who have not responded to at least 2 trials of SSRIs. Treatment refractory or intractable refers to a greater degree of non-responsiveness, such as failure to respond to a variety of OCD treatment strategies. Response to treatment is measured with the 10-item Yale-Brown Obsessive Compulsive Scale. Students, I have used that. It's a very useful scale. No OCD symptoms scored as 0. Extreme symptoms are scored as 40. A response is a 25% reduction of symptoms from the baseline score. OCD exposure and response prevention. ERP is the only treatment that consistently is effective for OCD. It consists, you can see these 6 things, students, that therapists work with patients who have this exposure and response prevention training. Behavioral therapy for OCD. Students, you can, review that. Neutralizing strategies for OCD. In addition to compulsive, repetitive, and ritual behavior, some individuals with OCD use neutralizing strategies to reduce stress. Strategies include seeking reassurance from others, overanalyzing, which they typically do, rational self-talk, replacing a bad thought with a good thought, the rubber band, if you've heard of that technique, especially with children. When you have a bad thought, flick the rubber band and think of a good thought. Performing brief mental or behavioral acts to improve the thought, and using a distracting activity and thought stopping. Treatment of trichotillomania. It's a combination, students. I've worked with a therapist at the VA who did habit reversal therapy and cognitive therapy. Again, anaphylol has been found to be effective and possibly more effective than SSRIs. The combination of Zoloft and HRT are more effective than, either treatment alone. Patients who have not responded to treatment with SSRIs have responded to augmentation of SSRI with an atypical antipsychotic, yes, such as risperidone. Some response to mood stabilizers have been reported, and results of naltrexone are inconsistent. Then treatment of excoriation. Prozac or fluoxetine reduces skin picking behavior. I currently have a patient on Prozac who's doing very well on an 80 milligram of Prozac. He is no longer skin picking. In a more recent study, 42.1% of patients receiving Lexapro responded only partially or none at all. Anaphylol has been found to be more effective. One trial study has found Lamictal to be effective. No reports on CBT, but individual HRT has been found to be effective. Clinical implications, preliminary support for the use of anaphylol, and strong support for the use of behavioral therapy.